Hi, welcome to CR Arthritis at the Canadian Rheumatology Association and Arthritis Health Professions Annual Scientific Meeting. My name is Eileen Davidson. I am a member of the Arthritis Research Canada Patient Advisory Board, a writer for Creaky Joints and Chronic Eileen. It's my pleasure to be here today interviewing Dr. Nigil Haroon, is a scientist at the Krembil Reserach Institute. In 2016, he won the Young Investigator Award at the CRA and AHPA Annual Scientific Meeting. Nigil has 57 peer-reviewed publications. Some of them has transformed clinical care and prevention of cardiovascular disease in ankylosing spondylitis. It's my pleasure to be here today with him. Nigil, can you please explain us a little bit about yourself and your role in rheumatology?
Yeah, first of all, thank you, Eileen, for that introduction, and thank you for the invitation. It's always a pleasure to come to Arthritis Broadcast Network, and I know how important the work that you're doing is. So I'm a rheumatologist with a keen interest in spondyloarthritis, and specifically I work in the area of axial spondyloarthritis. My research program spans both clinical and basic science, and I have a translational research program that is based out of the Toronto Western Hospital and the Krembil Reserach Institute. We have the Schroeder's Arthritis Institute now, which combines different specialties that care for patients with musculoskeletal diseases. So we have a great team that I work with, and we have several trainees and basic science people who also I work with in this field.
Excellent. Now, for those of us that may not know, can you explain to us what spondyloarthritis is?
Sure. So as the name suggests, spondyloarthritis. So there is an arthritis there, but the main part that distinguishes spondyloarthritis from other kinds of arthritis is that the spondylo part, or the spine, is a main target for this arthritis. So the vast majority of individuals who present with spondyloarthritis would have back pain as a major symptom. Now there is a subset of spondyloarthritis where the predominant manifestation is peripheral. So the peripheral joints like the hands, the feet, and the knees, as an example. So those patients will be included under the peripheral spondyloarthritis group. And the majority of patients who have the axial involvement where back pain is a major feature, they'll be included under axial spondyloarthritis. So that's in a nutshell how the term spondyloarthritis comes and what it stands for.
There's a few different diseases under the spondyloarthritis category. Can you tell us the difference between ankylosing spondylitis, psoriatic arthritis, and non-radiographic axial spondyloarthritis?
Yeah, because of these different terms, it can get a little confusing at times. So let's start with the umbrella term of spondyloarthritis. Now, there there are several different diseases that are quite similar in several characteristics. That's the reason why they're clubbed together under the term spondyloarthritis. One of the reasons I've already explained, the involvement of the spine. So that's one major factor that is common among them. The other factor is the association with a gene called HLA-B27, and depending on which subtype of spondyloarthritis we're talking about, the prevalence of B27 may vary in those subtypes. For example, if you take ankylosing spondylitis, which is the classic or the prototype of spondyloarthritis, 85% of patients who have AS will have the gene HLA-B27. And the prevalence of B27 goes down as we go into the other subtypes. Another characteristic of spondyloarthritis, which again is shared by all of these diseases, is the type of arthritis. It doesn't affect a lot of joints. It affects only a small number of joints. We call it oligoarthritis. It could be as small as just one joint or maybe 2-3 joints. And usually these joints are large joints affecting predominantly the lower limbs like the knees or ankles, midfoot. These are the joints that are most commonly affected. And also the other major feature is that they are negative for rheumatoid factor and anti-CCP antibodies. So they are not like, they don't behave like rheumatoid arthritis. So these are the things which, can club them under the term spondyloarthritis. Now to distinguish them, probably we can start with the broad classification, which I already mentioned, axial spondyloarthritis and peripheral spondyloarthritis based on the predominant area that is affected. Now, within axial spondyloarthritis, we have the two conditions that you already mentioned. One is radiographic axial spondyloarthritis, then we have the non-radiographic axial spondyloarthritis. For all intents and purposes, a radiographic axial spondyloarthritis is treated as same as ankylosing spondylitis, although the criteria are not exactly the same, but practically they are the same. So what ankylosing spondylitis refers to are patients who have predominant spinal involvement. They have significant back pain. Because of back pain, they may have restriction in the spinal mobility. And if you do an X-ray, you will see changes within the sacroiliac joints, which are the target joints for this condition. So changes are evident in X-rays, in radiographic axial SP or ankylosing spondylitis. Now, there are patients who have exactly same symptoms, who have spinal involvement, back pain, restriction of spinal mobility, lots of inflammation, but if you do an X-ray, you don't see anything. So those patients are non-radiographic axial spondyloarthritis. In these patients, if you do an MRI, you'll pick up inflammation. So they do have disease. But it's just that it is a kind of disease that does not lead to X-ray changes, which is fortunate for if you look at long-term prognosis, structural changes are not happening. But on the flip side, because X-rays don't show much changes, the diagnosis may get delayed. People may think there is no major disease here, right? So that is the flip side of not having structural changes on the X-ray. You talked about psoriatic arthritis. Psoriatic arthritis can behave like axial spondyloarthritis, which is spinal involvement, but most patients who come with psoriatic arthritis usually have predominantly peripheral involvement, and as I mentioned before, it's usually affecting peripheral joints. But within psoriatic arthritis, there is a subtype that can also look very much like rheumatoid arthritis with multiple joints involved, hand joint involvement as well.
I know you did touch base a little bit about rheumatoid arthritis, but what would you say the key point differences between spondyloarthritis and rheumatoid arthritis are?
Yeah, so when we talk about arthritis in general, we may think that all kinds of arthritis are the same, but for a clinician who treats these diseases, it's like night and day. Rheumatoid arthritis is clearly different from spondyloarthritis. If you look at the genetics itself, they're totally different. If you look at family clustering, it is much more common to see family clustering within spondyloarthritis disease than rheumatoid arthritis. And you come into clinical presentation, you'll see that rheumatoid arthritis is a symmetric arthritis, polyarthritis. That itself distinguishes it from spondyloarthritis, which I mentioned affects less number of joints, is asymmetrical. For example, if the right elbow is affected, usually the left elbow is not affected. You may get one knee affected, one ankle affected. That's the usual pattern for spondyloarthritis. But for rheumatoid arthritis, usually the small joints, and the small joints can be either the wrist, small joints in the hands, MCP joints, interphalangeal joints, and when you see both hands together, usually there is symmetry on both sides. Another major feature, as I mentioned before, for spondyloarthritis, they are negative for rheumatoid factor CCP. They're usually positive in the majority of patients with rheumatoid arthritis. And also, if you look at the outside joint effects or extra articular effects, they are quite distinct between SPA and rheumatoid. For example, there are three major extra-articular manifestations you see with spondyloarthritis, which you always monitor in patients with spondyloarthritis. Inflammation in the eye or iritis, inflammation in the gut or inflammatory bowel disease, and skin or psoriasis, right? And for rheumatoid arthritis, there are many other things that you have to be very careful about and take note of in patients. For example, dryness of eyes, dryness of mouth, like Sika syndrome. You can have involvement of the cervical spine leading to atlantoaxial dislocation, chronic inflammation leading to amyloidosis. You can have involvement of the spleen. You can have serositis like pericardium and heart involvement. There are so many other extraarticular manifestations in rheumatoid that you always screen for.
Could you tell us a little bit about the comorbidities that come with living with spondyloarthritis?
Yeah, it's extremely important. So spondyloarthritis has been considered a disease of the young, and till almost 2 decades ago, there was not a lot of option to treat these patients, and it was sort of neglected, I would say, because whether you diagnose these patients or not, they just take an anti-inflammatory and that's it. But things have changed quite dramatically since the availability of biologics, first TNF inhibitors and now IL-17 inhibitors, and soon hopefully JAK inhibitors as well. So because of that, we are diagnosing these patients early, trying to identify these patients early and start treatment as soon as possible, because it can make a big difference in the prognosis of these patients. So there has been a significant emphasis on identifying these patients and treating early, not only because of the structural changes, but also because of exactly what you said, the comorbidities. For example, we did a study in Ontario looking at around 25,000, more than 20,000, around 22,000, I think, patients with ankylosing spondylitis, and compared them to 4 times that number of patients of the general population. And what we identified was quite stark. What we saw was a significant increased risk of dying from heart attacks and strokes. And if you look at strokes, it is 60% higher risk. That's a relative risk. And if you look at heart attacks, it's 35% higher risk. So as I mentioned, it's a relative risk. Because these are young patients, the absolute risk is much, much low, very, very low. You're comparing, for example, a 30-year-old patient with AS to a 30-year-old healthy person in the population. So 30-year-old healthy population has a very, very low risk. Compared to that very low risk, there is a 35% increased risk. So it is significant. Over, let's say, over a period of 10 years or 20 years, perhaps that risk builds up. So you have to be very careful. Can we prevent heart attacks and strokes from happening with excellent control of disease? I would think so, but I don't think we have definitive proof of such a long-term follow-up. But we do have proof from ultrasound studies, for example. If you treat patients with biologics and do Dopplers, you will see that the health of the vasculature and endothelium is much better in those who are treated with TNF inhibitors than not. So, some things to consider in terms of comorbidities.
Do you find a lot of patients are struggling with their mental health as well?
Absolutely. That's thank you for bringing that up. Again, another study that we did in the Ontario population, we looked at mental health and risk of actual suicidal risk as well. And mental health is definitely an issue. It is an issue with any chronic disease, and especially so with arthritis, including rheumatoid and ankylosing spondylitis, where patients suffer from chronic pain for a long period of time. And because of their physical limitation, they're not able to participate in social activities, and they feel a little isolated. That can definitely, add to the mental stress. We looked at suicidal tendencies in these patients, and we actually didn't find a significant increased risk in females, but in males there was a significant increased risk of suicidal ideation in patients with ankylosing spondylitis. Again, something we always consider, and we try to screen for. We have to be vigilant about this right from the primary care setting up to the specialist setting.
Mm-hmm. Now, does spondyloarthritis affect more men than it does women?
So again, our concepts around spondyloarthritis have changed quite a bit over the years. If you look at specifically ankylosing spondylitis, and we go back a few decades, it was thought that it never affects women. So if a woman comes to the clinic with back pain, they'll say, no, that's just non-specific pain or something else. It's not ankylosing spondylitis. And at that time, the ratio of male-female ratio was considered to be as high as 10:1. That a few decades ago, again, it changed to around 3:1. So if you look at pure ankylosing spondylitis, where the radiographic changes are present, still I would say males are more commonly affected than females. But if you look at the entire axial SPA spectrum, where you consider MRI as well as X-rays, females are equally affected as much as males. So that is very important to understand, because otherwise patients may go undiagnosed.
Absolutely. Now, do you have any research updates to share in the field of spondyloarthritis or ankylosing spondylitis, such as treatment and management guidelines or the prevention of these diseases?
Sure. I can talk about the poster that we presented at the Canadian Rheumatology Association. It's an important study. It's looking at one of the comorbidities that we mentioned, an extra-articular manifestation of ankylosing spondylitis. Uveitis, or inflammation in the eye, is one of the most common extra-articular manifestations that we see in AS patients. If you look at the entire period of follow-up of these patients, let's say 10 or 15 years of follow-up, up to 40% of our cohorts have ankylosing spondylitis plus uveitis, that combination. at presentation itself, at baseline itself, if you look, just take a cut of all the patients in our cohort, you'll see that around 25% of patients have uveitis. So it's a very common extra-articular manifestation. It is important to know because treatment can definitely modify this extra-articular manifestation. So patients, it has been well established that patients on TNF inhibitors, specifically monoclonal TNF inhibitors, have a significant benefit when it comes to uveitis because these patients have less number of flares or no flares at all once you start the biologics. And the use of steroids decreases. Because the use of steroid decreases, the chance of glaucoma and cataract decreases. So many advantages for these patients. However, the vast majority of these studies have been done in the radiographic segment of spondyloarthritis or the ankylosing spondylitis patients. So this particular study that was conducted, it's an open label study. It's a phase 4 study. It's an open label study. What was done was the drug certolizumab pegol was tried in the full spectrum of axial SPA. So both radiographic and non-radiographic axial SPA patients were included with the primary idea of seeing, compared to 2 years before starting the TNF inhibitors, how do these patients fare in the following 2 years, in the subsequent 2 years? Are both patients in both radiographic and non-radiographic group, do they both respond? Is there a difference between males and females? So these were the main questions that was asked. And as expected, there was a significant drop in the number of anterior uveitis episodes. And the other thing also which I should mention is these patients were at high risk of anterior uveitis flares because they were all B27 positive. They had at least 2 episodes of acute anterior uveitis in the past, without 1 episode being in the past 1 year. So if this criteria was satisfied, they were included. So started on open label certolizumab pegol treatment. And you can see that those who had 1 anterior uveitis episode in the past 2 years, it was around 40% before in the previous 2 years. That dropped to almost, I believe, around 9% or so once you start the biologic. Similarly, those are 2 acute anterior uveitis episodes. It was around 60% before, and that dropped to around 10 to 11% once the biologic was started. So there was a significant drop as expected. It's just proving the point. Yeah.
Wow, so biologics has definitely been a complete game changer for those of us living with arthritis.
Definitely.
As a rheumatologist, I know that you see a lot of patients, so you probably have some great self-management tips for those living with spondyloarthritis. To end the interview, can you share some of the most popular self-management tips that you hear from your patients?
Yeah, definitely. So the first and foremost thing that when I talk to patients, I see the anxiety and the fear of the unknown. A lot of that has changed thanks to the social media and the availability of a lot of literature online. But again, there is a flip side to this also. There is a lot of misinformation as well that is going around, right? And people come in with the impression that they've got the most severe form of arthritis that you can imagine, and all the complications that they read about is going to happen to them. That's sort of the initial feeling that you come in with. So you have to really, calm them down, try to explain that it is a big spectrum. You're really in the small area, which has a very good prognosis. Plus, the treatments have significantly changed in the last 2 to 3 decades. And in fact, patients with those who live with arthritis and who respond well to these medications, whether they're biologics or just disease modifying drugs, they can live a perfectly normal life as if they don't have any arthritis. There will be some who don't have 100% relief. Still, they will be so good that almost all their activities of daily living can happen without any issues. Quality of life is not affected. And then there will be a small percentage who have very severe disease that we try our best to control. And even in those patients, a significant benefit is achieved with these medications. So first and foremost thing that I tell patients is to understand that today is different from 10 years ago. There is a lot of hope, and the outcome and prognosis is much better. So have a positive state of mind. That's most important. And for that, to improve the positive state of mind, there are a lot of things that you can do, which also helps the joints. For example, doing exercises regularly. If it's not possible now because of COVID, otherwise, groups having groups to come together. For example, the Spondylitis Association, Canadian Spondylitis Association is a great example where they have local chapters, and the patients come together. They come together online or they come together physically. They discuss the latest advances. They talk about each other's experiences. They also talk about the facilities available in the community. For example, a very good physiotherapy center, a very good a gym, a very good exercise center, maybe yoga therapy. All these things, overall add and improve the benefits that can be achieved with just medications alone. So I would say regular exercises, a positive state of mind, and keeping a positive outlook overall is extremely important.
Definitely, I would agree. And the advances in medicine these have been astonishing. When I was diagnosed with RA, it was the same week that my grandma, or not my grandma, my aunt passed away, and she was wheelbound chair to a wheelchair for my whole life. So, and that's changed now because of biologics and the medicines that we have today. So
Definitely.
definitely bring up that point. Thank you today so much for being here.